Welcome, everyone. I'm Justin. I'm a research fellow in the Institute of Policy Studies, and I'm very pleased to have Martyn Hammersley and Huw Davies with us today. And this is going to be a conversation about evidence-based practice. Is it a myth? And Martyn was originally slated to present at the IPS Tote Board Conference in the 20th to 21st of October. But because the timing didn't quite fit, and so, but he's generously offered to have us record his presentation, and so this becomes like a prologue or a B-sides to the conference itself. And I'm very pleased that to have also Huw. I thought it would be fun. Huw is actually presenting at the conference itself, and so I thought it'd be fun if the three of us had a casual chat about Martyn's ideas. And then you get to hear from Huw later on. So Martyn is Emeritus Professor of Education and Social Research at the Open University in UK. And he's carried out research in the sociology of education and the media. But I know him particularly because when I was a graduate student in sociology, I read a lot of his stuff. He had done a lot of thinking about qualitative research and inquiry. And I remembered him talking about or thinking about writing about how do you evaluate qualitative research, what counts as good qualitative research. And so that had informed my own thinking about it. And I wrote a boutique piece called Genre Appropriate Judgments of Qualitative Research. And then years later, Martyn had contacted me last year, I think, and said, hey, this paper is interesting, and we chatted about that. I call it a boutique piece of research because nobody reads it. It's in the philosophy of social science. I think maybe 3 people read it, but of the 3 people that read it, they liked it. So that's what it is. Professor Huw Davies. So by the way, both of these eminent emeritus professors, they're both retired, and they're so kindly sharing their time with us. And Professor Huw Davies is originally a mathematician before he started work in public health and health services research. And he co-founded the research university, the research unit for research utilization, RURU, affectionately called RURU, I think. And I had read not the earlier publications, but the one in 2007 called Using Evidence. And I read that so many years ago, and most of what I understand about evidence-based practice comes from his work and his colleagues' work. And so I'm so glad that now I feel like I'm having a private tutorial session with these 2 eminent professors. This is Martyn's book. He wrote The Myth of Evidence-Based Policy and Practice 2013. I'm pretty sure I ordered Huw's book for our university library. So I'm responsible for requesting it for library, and I'll also request the latest book as well. So that's why we're here. And so over to you, Martyn.
Okay, so I'm going to talk about whether evidence-based practice is a myth. So an overview of what I'm going to talk about. I'm going to begin by outlining the history of the origins of the concept of evidence-based practice. Then I'll look at some of the criticisms that have been made of it. Then shift to the way in which it's been liberalized. This often signaled by a change from the notion of, from the phrasing evidence-based to evidence-informed. And then I'll end with some thoughts about the relationship between research and practice. Now, the idea that practice should be, practice of all kinds in lots of different fields should be informed by scientific evidence is quite an old one. That there have been arguments in favor of that for over a century. But a particularly strong version of the argument for the role of scientific evidence in practice arose in the 1990s. And this stemmed from the evidence-based medicine movement. what that involved was clinical epidemiologists in particular arguing that there was very little scientific evidence for the effectiveness of many treatments that doctors routinely used, and that some of these treatments could be ineffective, and some of them could even be damaging. And there was some evidence that there were some treatments that were used that were indeed damaging. What they meant by scientific evidence was evidence from randomized controlled trials, these the results from these synthesized in systematic reviews. A randomized controlled trial is a field experiment involving random allocation of people to a treatment and to alternatives to it. And it's designed to determine whether the treatment produces a desired outcome. The reason why randomization is used is because that controls many potential sources of error. And the sort of bottom line, the conclusion of the people arguing for evidence-based medicine was that doctors should use only treatments that had been shown to be effective by randomized controlled trials. So that was the initial, that's the source of the initial idea of evidence-based practice. And it's quite a stringent model in terms of both what kinds of evidence can be used and also in how the evidence relates to practice. Basically, the evidence is treated as showing whether a particular policy or practice works or not. And this idea that practice should be evidence-based in that stringent sort of way spread to other fields, to social work, for example, education, criminal justice, and elsewhere. It was also found appealing by policymakers who, at that time, many of them were motivated by what was called the new public management. And that was a concern to make public sector professionals and organizations transparently accountable. And the idea was that the availability of research evidence about what policies and practices work would be a kind of template against which you can check whether professionals were working in the most effective manner. And I think that's its value in terms of accountability, or perceived value in terms of accountability anyway, was one of the main reasons for the rapidity with which it spread across a number of different areas. Okay, if we look at criticisms of that original stringent model, some of them related to methodological issues. So it was pointed out that randomized controlled trials work well in testing drugs, in that there can be a standardization of treatment, a control of dosage, and accurate measurement. So you could actually exercise quite a lot of control over the nature of the treatment, both within the randomized controlled trial and later when the treatment was applied elsewhere. But the problem is that outside of drug trials, standardization, control, and measurement can be very problematic. If you, even within medicine, if you think about running randomized controlled trials with different kinds of mental health treatment, you can probably realize that standardizing the way in which each of those treatments is delivered is much more difficult than it is in the case of administering a drug. What's more, even with drug trials, a randomized controlled trial only tells us whether a treatment is effective under ideal conditions, those in which other factors which might affect efficacy are eliminated. So, for example, in medical trials, it's quite common to exclude people who have other illnesses than the one that the treatment is designed to deal with, or who are on other sorts of medication, because that might interfere with the assessment of the efficacy of the treatment. But of course, once you roll out the treatment within the population at large, you're administering the treatment to people who've got other conditions and who are taking other kinds of medication, and you don't know what the effectiveness of the treatment will be in those those wild conditions, if you like, those conditions where other factors are not controlled. So there's a sense in which that original model of evidence-based practice is a bit of a mirage. It works in the particular case of drug trials. It's more problematic when you extend it into other areas, even within medicine, but certainly in other fields. The other sorts of criticism that were made of that original model relate to the notion of what works. So the idea of that central to the notion of evidence-based practices is determining what practices, what policies work and what don't. But the trouble is, in medicine and elsewhere, if you look at treatments, what you find is that there's very often some sense in which they work for some people, that for other people they have no effects, and for some people they have damaging effects. And the issue really is the distribution between those three categories. You know, does the treatment work for most people and have little effect or damaging effect for only very small amounts, or does it actually work for very few people and maybe doesn't even, they think it works, it looks as if it works, but it may not actually be effective. So it's what works, what doesn't work isn't a clear-cut issue, and you have to look at the effects across a whole population, particularly when you're rolling a practice out rather than just testing it in a trial. The other thing, of course, is that there may be side effects that may or may not be picked up in a randomized controlled trial, and that always when one is using a particular practice, there are opportunity costs and actual costs, and these can sometimes be quite high, and those costs will vary across situations. So there's a sense in which what works in one context will not necessarily work in another. A third point is that technical effectiveness in achieving a single goal is often not the main concern in many forms of practice, because there are multiple goals, and the problem is that what strategy works in trying to achieve one goal may not work in helping you to achieve others. In fact, it may make the achievement of others more difficult. So that practice is more complex, I think, than that original evidence-based practice model assumes. Also relevant, of course, is what is feasible in practice given available resources, what's acceptable to clients, to the people on the receiving end, if you like, of any practice. And also there are ethical questions about what should and should not be done to people. So there are those two sorts of criticisms. There are criticisms that focus on the methodological issues surrounding the nature of randomized controlled trials, and then there are criticisms about the relationship between research and practice, what the research can actually tell you about what it would be best to do in practice in particular contexts. Now, in response to those criticisms, over time, what we find is what you might call a liberalization of that original rather stringent model of evidence-based practice, with various requirements being relaxed. And as I said earlier, that's sometimes been signaled by a switch from the phrase evidence-based to evidence-informed. I should say that there is a danger of caricature here, that I'm identifying a broad trend of change, but actually the views about evidence-based practice both at the beginning and today are diverse. There's always a range of views. So I'm picking out an overall trend, if you like. But the liberalisation involved, first of all, change to what counts as research evidence. So other kinds of quantitative evidence than that from randomized controlled trials started to be accepted, and also results from qualitative research, particularly where the interest was looking at the actual process by which a practice was put into effect, or where the concern was with the views of the people who the practice was, who were engaged, both those people who were engaged in delivering the practice and those who the practice was designed to help. It was often thought that qualitative research is useful in providing evidence about those things. Also, there were attempts to build links with users of evidence in order to make the, if you like, double fit the research to the needs of particular users. So the development of notions of embedded research and varieties of action research and participatory inquiry and so on. So that was the first sort of liberalisation in the kind of evidence that was treated as acceptable. The second change concerned how research was thought to relate to practice. So there started to be increasing emphasis on the fallibility of research evidence. Some accounts of randomized controlled trial tended to give the impression that they could demonstrate infallibly what would work and what wouldn't. Most people who were involved in running randomized controlled trials didn't make that claim, but sometimes that sort of claim was made. So there was increasing emphasis on the fact that although research evidence had a high level of reliability, it's not infallible. There can be errors in it. And the other change was an emphasis on the importance of practical experience and judgment in fitting or interpreting research evidence in order to decide what was best to do in a particular context. So over time, there's that process of liberalisation in both of those respects. So just to conclude really with a few thoughts about the relationship between research and practice in light of that history of evidence-based practice. It certainly seems to me that the liberalisation, the shift to the notion of, if you like, evidence-informed practice rather than evidence-based practice, recognising that different kinds of research can be helpful, but also that they can't tell practitioners what it would be best to do in any particular context. That move certainly seems to me to have been a desirable one. But there is a problem that that revised model is less headline grabbing, if you like. It's more complex in its view of the role of research. And it's less straightforward to implement than the original model. I mean, we can always ask, what does it mean to say that practice has been informed by research? The word informed is quite loose. It can mean a lot of different things. And so in one way, that's good because it recognizes the variation across context and that the role that research needs to play must vary, but the making a judgment about whether practice has been informed by research becomes more difficult in the revised, more liberal model. At the same time, although there's been a process of liberalisation, it seems to me that there's still sometimes unrealistic assumptions about what research can provide. There's sometimes an assumption, for example, that it alone can supply an answer to any practical problem. So when you're faced with a problem, the question is, what does the research tell us? Can the research tell us, that we should be doing this rather than that? And I think what I've tried to suggest in looking at the criticisms that were made of the original notion of evidence-based practice is that research can't tell you. It can help you to make a decision, help you to make a better decision, hopefully, but it can't tell you what to do. There's also a problem that quite often research is used in contexts for the purposes of accountability. And so that what's involved within organizations, for example, is to use research findings in order to assess how effectively particular people are working. The problem with that is it introduces a number of biases, not least, of course, the fact that people are going to try and put on the best front they can when they're being assessed for accountability purposes. And so it's important in contexts where research is being used for accountability that potential bias is recognized. So it's important to recognize the limits of research as well as its potential for improving practice. It's not a substitute for the pragmatic wisdom that can be derived from practical experience. It's simply an important supplement to it. Okay, and I'll stop there.
Thank you so much, Martyn. There's so much I want to discuss. I think I'll focus on 3 areas, and Huw can jump in. The first thing is, well, I must set the context that in Singapore, I think that especially for the nonprofit sector, the orthodoxy of evidence-based practice is still very much in place. And like you said, the complex view of evidence-informing practice is not as headline grabbing as the simpler view, which is that science produces the evidence, and then somehow the scientists got to get these pesky professionals and practitioners to use quality evidence and to adopt them in practice. So that's, I think, where I'm coming from. And at least I really liked how you set the context of how this came from clinical epidemiology, and that perhaps even in medicine, it doesn't quite apply. But when it applies to other sectors like social services or education, it becomes even more problematic. And so you talked about, I wanted to kind of get your thoughts on, or at least to flesh it out for our nonprofit organizations as they're thinking about this. So possibly a kind of randomized controlled trials for drugs that works reasonably okay. But for social interventions, let's say something like a peer support group or learning circles, there's no standardization of treatment in the sense that a peer support group is not one intervention that is the same in every peer support group. There's no control of dosage, like you said. Maybe you meet for 2 hours, but is that a 2-hour dosage? Or you have 5 people in your peer support group, or maybe 10. Does that count as more? And also the accuracy of measurement. How do you do that? And so I wanted to kind of maybe help elaborate on what the difference between these kind of interventions are, and then how would you advise nonprofit practitioners to think about this?
Well, I mean, I think one thing I wouldn't want to argue is that in those contexts, randomized controlled trials are of no value, that evidence from them is of no value. But I think in interpreting it, you have to take account of the problems involved with standardizing treatments and also measuring outcomes, because very often the outcomes that people are interested in are very difficult to measure, and that it's often multiple outcomes as well. I mean, I think that also I would say that in those contexts there is an important role for other kinds of research, because if the form of practice that you're trying to assess can't be easily standardized and varies. I mean, one of the reasons why it can't be standardized is a lot of these practices are interactive. So it's not just a matter of what the practitioner is doing, it's also a matter of how those people the practitioners are interacting with, how they respond. And what happens is an interactive outcome. Now, given that you've got that interactive process, that seems to me to suggest that it would be of value to use qualitative methods to document the process that's occurring. So what that does is rather than you assuming that you know exactly what the practice is that's being assessed, the research would be able to tell you more about exactly what form it took on particular occasions. And that also would give practitioners a sense of what the different options are, the different alternative ways in which what, is broadly the same strategy might actually be used in different contexts. Also, I think that both qualitative research and social survey research, for example, can be useful in giving you a sense of how the people on the other end of the practice are responding to it. How do they see it? What difference does it make for them? So in a peer support group, how did they actually find that experience? What did it help them to do? What it didn't help them to do? I think where you're looking at practices in those social, educational, and other contexts, then you need those other kinds of information as well as any notion about whether some standard practice works or not.
Thank you, Martyn. Huw, I was wondering if you had any thoughts on this. So let's say, go ahead.
Absolutely, Justin. I mean, that's a great question that you've honed in on there, and it gets to the heart of many of Martyn's and indeed my own concerns about the evidence-based or evidence-based movement, if you like. Is that the RCT approach is fundamentally a kind of black box approach. It sort of crunches the data and says, in aggregate, does this produce benefits, often for quite tightly defined subject groups, as Martyn has outlined. And yet the real questions we're trying to answer is where does this work, with who and how, in what context, and how can we nudge it or shape it or improve it so it produces better outcomes for us. And so for me, the central challenge there is to theorize, is to kind of have some theoretical understanding about why the intervention that we think might have some decent effects, how it might work and who it might work with, and what would be its components that lead to these kinds of beneficial outcomes. And so it's really all about trying to unpack that black box and figure out what's going on. And that necessarily leads you to a multiplicity of different research methods, many of them qualitative, and some of them participatory as well, because we clearly need to know much more about how it feels to be on the receiving end of these kinds of interventions, as well as how it feels to be delivering those kinds of interventions. What is the magic alchemy that happens in, for example, peer support groups or other types of interventions of that ilk? So we need a much more sophisticated way of thinking about what research is and what research can offer.
So if I have a scenario, assuming I'm running a nonprofit, and maybe I create a program which is learning circles for marginalized youth, and the learning circle uses peer learning. So I get relatively older kids to teach younger kids. So, teach them math, and the best way to learn is by teaching, right? And so this, then they don't have to spend money on tuition, for example. And so let's say that concept, I'm implementing learning circles. And then my funder tells me, we want you to evaluate your program. So, and the funder thinks that the RCT is the gold standard, right? What would you then recommend that I do? Do I try to standardize the learning circle to the extent that an RCT is plausible and comes up with okay results? Or do I say, maybe RCT is not the way to go, and, try other forms of research?
Are you asking me?
Both of you.
Well, I mean, it's difficult, if not impossible, to answer that question, because I think I mean, the first thing I would say is that you would need to talk to the funder about it and get some sense of why they think a randomized controlled trial is the best way to do it, how committed they are to that. If there might be possible to negotiate a different kind of evaluation that would take more account of the variability and the processual character of the intervention. if it's not, then what I would say is, well, I don't think I'd try standardizing the standard, because I don't think that would work. But I think you could still try and run something like a randomized controlled trial, but I would supplement it with some other sources of data as well. Because the other thing is that, in my limited experience, funders don't always know what they want. So, they might well say that they want a randomized controlled trial, but if you provide some other evidence as well, they may well actually come to be quite impressed by the other evidence. So I think it's complex. You'd have to, it is in itself a negotiated process. You'd have to see what's possible and what would be the best thing to do in that situation. But again, it's an accountability situation as well. So the problem is, it's not, although yes, we're interested in whether it's effective or not, but also, the outcome will have implications for whether you get future funding or not. So it's quite a messy situation, I think, that.
So Justin, I would say that for any social intervention of the sort that you're describing, is that there's a real spectrum from something that is a promising idea, if you like, something that's innovative, through to things that have got a degree of establishment behind them. They've been tried, they're pretty well understood. It's about how can we adopt them and adapt them into local circumstances. And the questions you're asking of those interventions that sit in different place on that spectrum are quite different. So for the promising idea, for something that's truly innovative, you're asking really, can it work? Can it offer some benefits? And can we understand its mechanisms more clearly? For the more established interventions, the things we know are good ideas because they've been tried elsewhere, and we're wanting to adopt them locally. The question is, well, how can we implement them and how can we improve them? And they require very different research strategies. Excuse me a moment. And so I think we need to choose our research methods with great care, and also we need to specify our research questions with great care. And that's often done in dialogue with the funder. What do they think they're funding? What are they trying to achieve? Are they trying to reassure themselves that money spent locally is well spent, is producing the sorts of outcomes they want? Is it an accountability issue? And is that why they want data? Or are they trying to generate or add to a body of knowledge that can be used elsewhere so that an intervention can become more established and can perhaps be rolled out in other settings? In other words, are they trying to make a case for an intervention? So they're looking there for transferable data, for generalizability. So there's a real process of dialogue that has to go on with the funder, I think, to figure out what it is they want to know and why do they want to know that information.
What do both of you think of when would the conditions be right to do a randomized controlled trial in social types of interventions? Only when you want to scale the program that is highly stable and already showing results. Would that be the only scenario where you even consider doing a randomized controlled trial?
I think you need to know a good deal about why you think the intervention works. What are its mechanisms of action? So you have to have some very strong theory about in what ways does the mechanism work, for what kinds of participants, under what kind of circumstances. And when you understand that, you can then design a trial that can test some of those mechanisms of action out more effectively. Otherwise, there's a real risk that all you're doing is getting an aggregate group of people, as Martyn said. You can have a group of people for whom, for most people, the intervention makes no difference. For some people, the intervention makes a beneficial difference, and for other people, it's positively harmful. And you go searching for an aggregate effect, which doesn't show anything terribly much, and certainly doesn't show anything of any great interest. So until you've got a clear idea about who the intervention should work for, under what circumstances, I think you shouldn't be jumping into a randomized controlled trial.
So I gather that. Sorry, go ahead.
I was just going to say I agree with you very much on that, and I mean particularly the point about mechanisms, about understanding how an intervention might be working, you know, in what way it works with different groups of people. One of the defects, if you like, of the original evidence-based practice model that I didn't mention is that there was sometimes the belief that you don't have to know how it works, you just have to know it works. And that's always struck me as a really false assumption, that with any intervention you need to try and get some sense of what the causal mechanism is. If it's having a particular effect, why is it producing that outcome? The difficulty, of course, is that with lots of interventions, that the causal processes involved are complex and variable across situations. So I think you certainly must try to theorize them in a sense of getting some idea of how it will work in different types of situation. But as you said, you've still got the issue of, but how is it going to operate in this particular situation? And I think that's an important thing to remember, and it's part of what it seems to me. It's part of what is intrinsic to what you might call best practice, to the way in which practitioners should operate, which is as reflective practitioners, that they're thinking about what they're doing, why they're doing it, what effect it might be having, why it might be having that in effect. And the function of research, as far as I'm concerned, is to help that process. It gives you additional information about what might be happening here and what conditions affect it and so on.
That's so interesting, because go ahead, please.
Can I just follow on from that, really? Because Martyn, I was thinking about from your presentation, which I very much enjoyed, and like me, you have the benefits of a very long perspective on these debates, and a healthy dose of realism as well about what we can do with evidence. But I wanted to ask you whether you thought, looking across the piece at the evidence-based movement and how it's morphed and changed over the years, whether there's been too much emphasis on the research supply side and an insufficient attention at the, if you like, the knowledge demand or knowledge dynamics side of things. So we see an awful lot of attempts to increase the sophistication of research methodology, for example, to do larger studies, to do mega trials, to fund a lot of systematic review work with the Cochrane collaboration and the Campbell collaboration. We'd see the formation of portals that give you access to research summaries and so on. And I think that we need to spend much more time looking at the sort of demand side, the knowledge dynamic side, where research actually might get used and might be influenced. And I wondered what your feelings were on that.
No, I agree entirely about that. I mean, one of the annoying phrases that is often used is the idea of translating research into practice, and I just don't think that's the issue. If you're wanting to help some practitioners, policymakers, whoever, to improve what they're doing, you start with what they're doing, how they see it, what they need, and then you think about how research could help. I don't think you start by doing some research which judges whether it's effective or not in some broad aggregate fashion. You know, I mean, I'm not saying that kind of broad randomized controlled trials are of no value. It's just that they don't do the job on their own. You have to start at the other end. They offer information that you can use in the process of helping people to assess their own interventions and to improve their practice.
I think you're absolutely right, Martyn. And you alluded to this in your talk, that there's an unfortunate entanglement between evidence-based or evidence-informed would be the expression I would rather use. I'd settle for evidence-aware, but evidence-informed policy and practice. There's an unfortunate entanglement between that and new public management, a set of themes and approaches that came to the fore in the 1990s in many different guises that were much more coercive, much more about performance measurement, performance management, more about accountability, that had a sort of centre-right approach to human nature, essentially, that people need to be coerced into delivering on the right kinds of things. And I think the movement has really struggled to get out of those confines over the years. And my generally optimistic view about evidence and policy and practice is in part driven by a desire to escape those rather dark and oppressive shackles, really, from the 1990s, and to see it turned into something that becomes much more empowering for professionals and practitioners, and indeed service users, to have more informed ways of doing things rather than something that is driven by top-down diktat to coerce people into doing evidence-informed programs.
Yeah, I agree, and I think the irony about those various the uses of research for accountability purposes is that it actually didn't provide the information that it was claimed to be providing anyway. So what you got was this process in which an interaction between the people who are doing the assessment and the people who are being assessed in such a way as to fabricate a false picture of what was going on, because on some occasions it was in everybody's interest to do that. But that means you get no sense of what's actually happening and what effect it's actually counterproductive. It's most unhelpful, I think.
This brings to mind, I had once I chatted with a kind of job placement service, and the person said that he, based on the KPIs that he was given, which is, place how many people in how many jobs and how long they keep their jobs, he would then work with his close partner. So if he works with a restaurant, and then he would continue to push, for example, employment of marginalized groups or people with disabilities towards this company, because they've been willing to absorb his clients. So it became a highly structured pathway to a low-paying job. Because that hits the numbers, the better jobs are much harder to achieve. And so he's not even going to look at that.
Yes. Yeah, that's exactly the kind of thing that happens. Some sort of shortcut is often found to producing what looks like the best outcome, but it isn't. Very often it isn't a good outcome at all.
I wanted to ask both of you about cases whereby, I noticed that cases whereby evidence-based practice led to some kind of implementation of a policy. And I read in both of your books that there's an example on obesity and the use of phonics, and whether you could talk about that, the negative consequences of over-relying on RCTs to generate evidence and taking it in a kind of narrow, singular dimension.
Well, I suppose the example that I would use from here in the UK is the use of RCTs to assess different ways of teaching children to read. So there was quite a long time ago now, there was a trial. I'm not sure it met all the requirements of a randomized controlled trial. I'm struggling to retrieve things from my memory at the moment, but it claimed to show the effectiveness of a form of teaching that was based on phonics, and it was quite influential in shaping government policy. And there've been quite a lot of methodological criticisms of that original study, but I mean, there've been subsequent studies as well, and as you usually find, actually the results are much more complex than the original study suggested. But I mean, the other problem that what that case nicely illustrates is that it's randomized controlled trials can tell you about some particular aspects of what you're interested in, but they can't necessarily tell you about all of the things that you would need to take into account in making a sensible decision about something. So in the case of children learning to read, it may be that phonics is more effective at enabling children to recognize words or characters or whatever but it's not necessarily better in terms of finding out whether they are understanding what they're reading or whether they're enjoying reading. And much of the argument about different ways of teaching reading has actually not so much been about what's effective, it's been about what emphasis one gives to those different aspects of the things that you would want to see happen, not just children being able to read text, but also to understand it and to enjoy reading and so on. And I think what that indicates is firstly that you need different sources of information about how children experience different ways of teaching reading, but you also need some discussion about, what should be the priority in terms of emphasis. What is it that we most want to come out of, some intervention in terms of helping children to learn to read. And I think one of my concerns about the earlier notion of evidence-based practice is that it takes attention away from those, if you like, value issues about, so what do we think is most important, and focuses everything on, what's effective and what isn't. And I think that's another way in which it's destructive of good decision making.
Absolutely, Martyn. I'd really reinforce that. Any approach that presupposes that we know preset what the desirable outcomes are and how we value those vis-a-vis other outcomes is presupposing an awful lot about what matters. And I don't think you can reduce these arguments to a set of technical considerations of how you simply reach those outcomes. There's a much broader debate about what outcomes are appropriate, and indeed what processes and what process value there is in reaching those outcomes. But I wanted to draw attention to a slightly different issue, Justin, and this is an area where I think the evidence-based movement and the debates around evidence have been very deficient over a large number of years, and that's the lack of attention paid to power in the dynamics. So we all know that knowledge and power are intimately connected, and obviously in a fairly facile way. The more knowledge you have, the more powerful it makes you. You know stuff that other people don't know, and therefore that puts you in a more powerful position. But much more disconcerting is the idea that knowledge is what the powerful say it is. And we see this happen time and time again. For example, if you look at the way in which government departments operate, they can assert the quality of evidence. They can say the evidence shows that we're going to do this. And because they are in powerful positions, they're able to carry that argument. If you think about a different organizational setting, so you were talking about the teaching of reading in schooling, but if I think about, say, a healthcare setting where you've got a multiplicity of different actors with different views about what matters and how to achieve the sorts of outcomes that matter, it's very clear that the senior medical leadership are able to assert ideas about knowledge much more effectively than less empowered people in that organization. And I'm particularly thinking of, for example, nurses and other staff. And so the ideas of evidence are often used as a sort of stick to beat people with, often a very conservative way of saying, where's the evidence? Where's the randomized control trial? And therefore, if we haven't got a randomized control trial, we're not going to do anything. We're not going to change. Or flip it the other way around, and a person in a powerful position, like a senior medical director, can assert that we've got evidence and pursue a change in structure or in practices within a setting off the basis of really quite poorly constructed studies. But because they're in a powerful position, they're able to assert that this is good enough evidence. And I think the whole movement has been very slack in terms of analysing the role that power has to play alongside evidence.
It brings to mind, and Martyn might be familiar with Andrew Abbott's work on the system of professions. He's a sociologist that studied jurisdictional competition between professional groups. And so he calls this space, largely the non-profit sector space, on the personal problems jurisdiction, which used to be, nobody wanted this space, and then clergy were in on it, and, they counsel people on their personal problems. And then the doctors came into this space, and of course, the psychiatrists being able to medicalize the knowledge in this area. And then they said, only we can solve parts of this problem, and only we can prescribe drugs. And then there's this constant battle with the clinical psychologists on whether clinical psychologists can also prescribe drugs, and they know better than psychiatrists. And then, like you mentioned, there's kind of like a hierarchy of professional credibility. Then there's the social workers and the counselors who occupy a more marginal space in being able to define what counts as evidence in the space. And so I really do resonate with that. But I wanted to ask also if you feel that, I know some scholars have pointed out that even the professional self-interest also cloud this area, in the sense that if you are, let's say, a psychologist, the tendency is to view social or structural problems as individual problems, for example, or to see, poverty or marginalization as a kind of the lack of resilience, let's say. And so it individualizes a problem instead of see it as a structural issue that requires policy change. I wonder whether you had thoughts about that.
Well, yes. I mean, I think that is. We all come from a particular direction. We all have particular assumptions, and it leads us to particular sorts of conclusions. And as Huw has pointed out, our interactions take place in contexts in which there are power structures and there are power processes going on. And I think there has been that's not been recognized sufficiently in thinking about the relationship between research and policy making and practice. I mean, I've often, in thinking about it in relation to education, I've often wanted to argue that, in a sense, you've not got a relationship between research and practice. You've got a three-cornered relationship between research, policy, and practice, and you've got tensions and attempts to use the one or other of the other elements of it, going on all of the time. I mean, I don't think power structures are simply determine what's going to happen, but you have to take account of them in your engagement with other people. But I think also you have to take account of the way in which your background and your situation shapes your own assumptions. One of the benefits that can arise from the kind of more interactive process of researchers seeking to assist policymakers or practitioners is that both sides can actually learn something from it, in terms of learn about the assumption that they were making that they didn't realize that they were making that may be problematic. But it's not a simple thing to bring about, and bringing about a fruitful collaboration, I think can actually be quite difficult. And there's an element of luck in it as well, as to both in terms of the people that you're dealing with, but also the particular time that you are engaging. There are some times when change it's much more possible for particular sorts of change to happen than at other times, and it's a messy and complex business, bringing about improvement to forms of policy and practice.
I'd add to that, Martyn and Justin, is that there's a sense in which the evidence-based movement, the idea of evidence-based practice that is particularly focused around how interventions work, do they produce the sorts of desired outcomes, they overemphasize and marginalize aspects of the problem. So they overemphasize individuals and change within individuals, and it being an individual problem, and they marginalize structural issues. So if you take three typical problems that are perennial concerns for most public policy. So obesity, for example, how we deal with a growing obesity problem in many developed nations. How we deal with alcohol consumption in many nations, how we deal with tobacco consumption, or how we deal with problem gambling behaviours. All of those are constituted as individual problems for individual intervention, and what works in helping people to lose weight, what works in helping people to reduce smoking or reduce alcohol consumption or reduce problem gambling behaviours. And that very framing of the problem constitutes the problem as failures of individual practices, and draws attention away from the structural conditions that give rise to those problems in different societies. So there is a real sense in which the way in which we frame problems smuggles through a set of assumptions that may be quite damaging and are certainly contestable.
I notice time is running out for us, but so maybe to move on, so we talked about all this, the problems with evidence, the linear rational model of how evidence works and what counts as evidence, towards a more kind of organic, ground up or demand driven model. And I was wondering if you had lessons for how a non-profit organization here can think about engaging or producing evidence in a way that speaks to the power structure, in a way that, because they typically don't have a lot of power, they take funding from government and foundations. And so they basically kind of typically go along with the program. They find it hard. I mean, even as a researcher, sometimes I find it hard to explain to funders why the most rigorous form of gold standard evaluation may not work. And then it depends on who's telling them, right? So if they hear it from you, they say, right, that makes sense. If you hear it from a non-profit leader, they say, I think you're just making an excuse for not doing the right thing for your program. What advice would you have for them, and maybe some of the lessons that have happened in the UK?
Well, I don't think I can offer much advice about that, to be honest, partly because I think it, I agree very much about the role of power structures, but the thing about power structures is that they're different in different countries and in different localities, and they, to some degree, they adapt to different issues and different circumstances as well. So what the best way of dealing with any particular set of power holders is on any particular occasion is quite difficult to say. I mean, certainly, following up on what you've just said, one strategy is to see if you can find somebody who will validate what you're wanting to do, somebody who the power holder would accept as being authoritative. But it's not always easy to know who that would be. I mean, there's quite a lot of suspicion of expertise in a lot of contexts, or particular kinds of expertise. So I find that quite difficult to answer.
So I would tackle that, Justin, by saying that if we take the kind of critique that Martyn's offered seriously, and if we look at the debates that have proliferated over the past 20 years, and we take those debates seriously and try to learn from them, and we look at how those debates have played out in other sectors, and not just try and take the evidence-based medicine model and transplant it into other settings, but look at how the evidence debates have played out in, for example, social work and social care, or how they've played out in international development, or in the environment and sustainability, where very often these debates have happened somewhat in isolation from each other, and so haven't always been so hidebound by an evidence-based medicine model. If we look and learn and reflect from that, we can see that we often both demand too much of evidence and at other times expect too little of it. So by demanding too much of it, we expect evidence to be somehow the arbiter of what we should and shouldn't do in an accountability framework. And I think that's often a very unrealistic way of viewing it. How we expect too much of it is that data are always interesting, carefully gathered data with some proper theorizing behind it, properly discussed and shared and entered into with dialogue with people who are affected by that data, can really start to give us some insights. And so where I'm going to take my presentation is partly by looking historically at where we've got to, partly by looking cross-sectorally at other different sectors, and partly by looking, if you like, across the piece of the organizations and management field, which has generic interest in knowing and doing. How do we know stuff, and how do we get stuff done? I mean, I think that is essentially the kind of core concerns of organizations and management. And if I try and integrate across those three different things, I think three themes come to the fore. The first is that we need to be much broader in terms of what we look at in data and knowledge. So we shouldn't just be looking for effect sizes for randomized controlled trials. We need a much broader array of data on who has problems, what kind of problems do they have, how does it feel, what's the lived experience of having those problems. We need a much broader array of knowledge that draws not just from the formal research base, but also draws on practitioner experience of delivering programs, and particularly on user experience of being on the receiving end. So we need a breadth of data and knowledge coming into the conversations. We need a plurality of voices. We need to try to address and dismantle some of the hierarchies of voice, so that we have a greater variety of people engaged in those conversations. And particularly I'm thinking of service users. And we need to stop seeing knowing and doing as somehow separate, that somehow we can get the knowledge that will tell us what to do. And then the second problem is we'll figure out how to get that to happen on the ground. But we'll start to see knowing and doing as intimately co-constructed, that people learn through doing. And so that we have learning organizations that are constantly looking at the data being generated from their practices, learning from that data, as well as being out and scanning and looking at what the research base has to tell them, so that you have this dynamic change in an organization, rather than one that says, let's take a program off the shelf, we know it's evidence-based, it's been shown by an RCT to work, and now let's just do it here, which is a much more of a pipeline model to evidence. So those are the sorts of themes that I'm going to come to in my presentation.
Yes, and please, conference, if you want to hear Huw elaborate on those ideas. I'm so glad that you come, and I'm so glad that I have this private tutorial session that can then be recorded and shared with everybody else. Maybe one last thing, maybe that you could say, maybe one sentence to reflect on what I'm going to tell you, which is, I know this organization and they're doing great work, right? They work with people with autism and they try to get them jobs in the IT and engineering sector. And so they hire job coaches, they work with the caregivers, and they troubleshoot. Sometimes the person with autism shows up and then the manager's not there and doesn't know what to do because it's outside the standard operating procedure that he's been trained. And so they go down, they troubleshoot, and they solve all sorts of problems. And then I chatted with them and they said, we do all these things and we feel so anxious, we're so insecure because I wish the research can tell us what to do and whether what we're doing is correct or not. What would you say? And I'm thinking in my mind, my gosh, these guys are doing exactly what they should be doing, trial and error, learning from experience, tweaking things. What would you say to them?
Well, I mean, I would say, first of all, that research can't tell you what to do. Which is a theme through all of what we've been talking about today. But I would say that, well, look at what research methods might be available that might help you to be able to not just provide evidence about your practice, but also would help you to see how it could be improved still further.
And I would say that professional expertise is so much broader than research-based knowledge. I would hope that professional expertise is informed and certainly aware of research-based knowledge, but professional expertise is so much broader and should be valued for that. So the knowledge that you have as a professional comes from experience, and it comes from collaborating and dialogue in communities of practice, and I would not want to see that sort of knowledge de-emphasized.
Thank you, Huw, and thank you, Martyn.